And so I basically stalked him at one of our meetings and introduced myself and told him my little story and said, how's that possible? And being a great mentor, as all mentors are, he said, it's a great story. How much time you got? Where are you going to next? Here, let's go sit in the back of this room. And so we sat in the back of the lecture hall for 3 hours, and he told me all about CPT and RUC and coding, and it was really encouraging. And so we would email each other back and forth for the next year or so anytime I had him questions. And then in 2006, they decided that they were going to train like the next generation of coding people for SVS. And he sent me an email. He said, I want you to apply for one of these trainee spots. And so they had 4 of them, and I got one of them. And so I've been doing health policy with SVS for 10 years now. So let's see. I can move this forward. So, for the residents and students out there, why don't you care? Well, when I was a resident, we didn't really care about coding. We were focused on patient care. We were trying to do all the cases we could do. None of the codes seemed to make much sense, so just didn't care about it. The coding terminology, there was too many letters, right? CPT, ICD, E&M, RVU, RB, RVS, RUC, modifiers. None of it was really intuitive, and we were just caring about learning surgery. So, let's start with evaluation and management. So, evaluation and management codes, or E&M visits. What's the difference between the types? What's the difference between the levels? They come 1 through 5. Some of them are 1 through 3. There's inpatient, outpatient, initial, subsequent. What's a straightforward physical exam? What's a comprehensive physical exam? Why don't they line up? So there's 5-level visits, but only 4 types of history, physical, and decision making, so that doesn't make a lot of sense. The difference between a consult and a new patient, you don't have to worry about that anymore because Medicare just decided they'd quit paying for consults, so those went away. So the components of a visit, you have the history, okay? When you break down the history, they break it down into chief complaint, HPI, past family social history, and review of systems. Chief complaint, concise statement describing the symptoms, problem, condition, diagnosis, or other factors for the encounter, usually stated in the patient's own words. The HPI, chronologic description of the patient's illness and symptoms, including location, quality, severity, duration, timing, context, modifying factors, associated signs and symptoms, etc. It can be brief, 1 to 3 elements, or extended 4 or more. You can, with the 1997 guidelines, if you discuss 3 chronic illnesses, that also counts. Past family social history, these are pretty self-explanatory, and like I said, I have too many slides, so I'll move along. And then review of systems, this is the list of that CMS considers the different systems that can be reviewed. You can either have a problem pertinent review of systems, where you just review the system directly pertinent to the HPI. You can have an extended, which is problems in the HPI plus a limited number of additional systems, or you can have a complete, which is reviewing all the systems, okay? So, based on those parts of the history, you can bill a history visit as either problem-focused, expanded problem-focused, detailed, or complex, and this gives you a little grid of what each of those are. The part I want to highlight is really the difference between a detailed and a comprehensive is how many systems you review. So way back when Dr. Spain was yelling at me for just saying review of systems negative, he was right. Physical exam can get a little more confusing because there's 1995 guidelines versus 1997, and apparently these were so painful to write that they haven't even bothered to revisit those since those time periods, and I don't think there's any plans to revisit them in the future. So you can do a physical exam, and this makes absolutely no intuitive sense to any of us who've been through med school and actually take care of patients, but this is the way the coders and CMS looks at it. So you can either do body areas, which are head, including face, neck, chest, including breasts and axilla, abdomen, genitalia, groin, buttock, back, and each extremity, or you can do organ system, eyes, ears, nose, mouth, and throat, cardiovascular, respiratory, GI, GU, musculoskeletal, skin, neurologic, psychiatric, and hematologic, lymphatic, immunologic. So the 95 guidelines were a little vague, more flexible. It was fairly subjective, so auditors didn't really like it, and you have 10 auditors and get 10 different opinions. But basically, on the 95 guidelines, a problem-focused exam is one organ system or body area. Expanded problem focus was 2 to 7 organ systems and or body areas. Detailed was 2 to 7 systems and or body areas, but extended, so several bullet points. And then comprehensive is a complete multi-system exam. The 97 guidelines gave you the 11 they have single specialty exams, so they have ones tailored to different specialties. Each area contains bullet points in the exams, and it's a little bit easier for the coders because you just count the bullets to get the level. So in 97, the problem focus is 1 to 5 elements. Expanded is 6 to 11. Detailed is 2 or more from any 6 areas, or more than 12 in 2 or more areas, and a comprehensive is 2 or more bullets in at least 9 areas. Confusing, right? Okay. So this is, again, how the next level for an E&M visit is decision making. So this is a 3-factor to determine complexity based on the number of diagnoses or management options, the amount or complexity of data to be reviewed, the risk of complications and or morbidity or mortality. And so to qualify level 2 of the 3 must be met or exceeded. So if you have minimal, limited, or multiple or extensive diagnoses, you can have minimal, limited, moderate, or extensive data, and the risk minimal, low, moderate, or high. And that gives you either straightforward, low complexity, moderate complexity, or high complexity. And so what I see a lot of time is people down coding based on medical decision making. It's pretty easy to count how much history you take and how much of a physical exam you take. And people think, well, I don't know how the medical decision making, I'll just kind of down code a little bit. But if you think about it, if you're making the decision to operate on somebody, okay, that's pretty much right off the bat. Your risk is going to be moderate to high, so you should be having a minimum of moderate complexity decision making if you've decided to operate on somebody, even if it's something simple. So, putting it all together. So, on the right column, you've got the different types of histories, physical, and decision making. On the left, you have it translated into codes. So if we're seeing a new patient, they can be a level 1 through level 5, and in the parentheses are the corresponding CPT codes. If it's an established patient, again, level 1 to level 5. And these are outpatient clinic visits. So, a level 1 new patient visit, problem-focused, history and physical, straightforward decision-making. Level 2, expanded, and then straightforward. Level 3 is detailed history, detailed physical, low complexity decision-making, okay? So for surgery, most new patients that you're seeing, if they've got a surgical problem, you're probably gonna have a level 3 visit, okay? Level 4, comprehensive history, comprehensive physical, moderate complexity decision-making. And level 5 is comprehensive, and high complexity. Now, when you're seeing established patients, it's exactly the same, except you only need to hit 2 of the 3 key components for the exam, okay? And then I want to point this out, the level 1 established patient visit, and I see this billed sometimes in the clinics for an established patient. I go, oh, that was pretty straightforward, we'll just make that a level 1. So this is straight from CPT, that a level 1 visit is an office or other outpatient visit for the evaluation and management of an established patient that may not require the presence of a physician or other qualified healthcare professional. Usually the presenting problems are minimal and typically 5 minutes are spent performing or supervising these services. Okay, so this level 1 established patient, this is the hypertensive patient that comes back to the primary care doctor's office and the nurse checks their blood pressure. Okay, this is not a surgical patient. So we'll just skip over that one. But for level 2, that's the problem focused, straightforward. Level 3, expanded, and low complexity. Level 4 is detailed history, detailed physical, and moderate complexity decision making. And a level 5 established patient is a comprehensive history, comprehensive physical, and high complexity decision making. Now, like I said, you only need to hit 2 of the 3 on the right side to determine your level of coding. The coders are going to go for the lowest 2. Okay, the lowest one is going to be one of those in the equation. For inpatient visits, again, codes on the left, history, physical, and decision making on the right. It's kind of the same, but the bar is a little bit higher than in the office. So the very bottom, initial hospital care, so this is your consult note, or this is your admission H&P. To even bill a level 1, you have to have a detailed or a comprehensive history, and you have to have a detailed or a comprehensive physical, okay? So for that history, that means you need to be reviewing at least 2 systems, okay? And for the physical, you need to be doing at least 6 organ systems. The decision making then is a little bit more lax. It can be straightforward or low complexity. Level 2, you have to have comprehensive history and physical, and that's your moderate complexity decision making. A level 3 initial hospital visit, comprehensive, and high complexity. The subsequent hospital care is just like the office. You only need 2 out of the 3. There's levels 1, 2, and 3. 1 is problem focused, and straightforward or low. Level 2, expanded, and then moderate. And then level 3 is a detailed, high complexity. Okay. There's 5 codes if your site of service is in the emergency room, and the bar is a little bit lower and easier to reach here. So for level 1 ER visit, it's problem focused, straightforward. Level 2, expanded, and low. Level 3, expanded, and moderate. Level 4, detailed, and moderate. And level 5 is comprehensive, and then high complexity. Critical care. This is billed completely different from everything we just talked about. Critical care is time-based, and it's time within a 24-hour period. It doesn't have to be contiguous, okay? So for the first 30 to 74 minutes of providing critical care to a patient, you bill a 99291. For each additional 30 minutes, it's a 99292. So if you spend 3 hours with somebody, you're going to bill 99291, and then, thank you, 4 more. I knew somebody would do the math quicker than me. So this one's purely time-based. So here's I put this slide at the end so you would at least listen to the first couple, but here's my Cliff Note version. So these were kind of the high points that I took away to kind of maximize billing with minimizing effort, which every person wants to do, right? You want to maximize results with minimal effort. So make sure you put 4 elements in every HPI, okay? If you put 4 elements in every HPI, you have an extended history present on this. It's not too hard to do. The difference between a detailed history and a comprehensive history is really the review of systems, okay? You only got to do 2 to hit the detailed, which is not too hard, have a bar to hit. To hit that comprehensive, you got to do all of them, or you got to do at least 10, okay? And just doing a complete past, family, and social history is what you need to do to hit the detailed and comprehensive histories. For a detailed physical, you need 2 bullets and 6 organ systems. For a comprehensive, you need 2 bullets and 9 organ systems. If you remember these kind of points, the rest of the coding falls into line. And if you make it a habit of doing that, then you won't be undercoding or being underpaid for the work that you're really already doing. Okay, so not too bad. So CPT ruck cycle. So this is where I've spent most of the last 10 years of my effort. When I joined the coding committee, there were 4 of us, and they kind of split us up, put 2 of us on CPT and 2 of us on ruck. And so I wound up on ruck and spend quite a bit of time there and working on that, and we'll talk about what that is. So CPT stands for Current Procedural Terminology. This is actually owned by AMA, and it's the numeric code that translates everything you do from a well baby visit to a trauma laparotomy into a 5-digit code. For the residents, these are the numbers that you're using for your operative log. If by chance there's something that you did that there's not a code for, there are these basket catch-all codes that are the dreaded 99 codes or the unlisted code. Unlisted might as well say unreimbursed, because you don't really get paid for 99 codes without a lot of effort. The manual is nice and thick. It's broken into evaluation and management, so we were already talking a little bit about some of the CPT. Anesthesia has a section. Surgery is basically 10,000 through 70,000. The radiology codes are the 70,000s. Pathology and lab are the 80,000s. And then medicine, except for anesthesia, is the 90,000s. Within the section on surgical codes, these are some of the highlights that everybody probably has done a little bit something within each one of these segments, but there's skin, musculoskeletal, respiratory, cardiovascular, hematic and lymph, mediastinum, digestive, urinary, endocrine, and nervous, and there's others in there that I didn't think were quite relevant. So my tip to you guys is know the codes that you commonly use and also know the section that they reside in. So for example, below-knee amputation is 27880, okay? But not all BKAs are BKAs. So you can do a guillotine, and that's a different code. That's 27882. You can do a completion amputation of somebody who's already had a guillotine, and that's not 27880, that's 27884. You can redo an amputation for someone whose amputation has not healed, and that's 27886. You can do a SIME amputation. So technically, according to in the CPT, it doesn't say below knee amputation. It says amputation through tibia fibula at any level. But if you do a SIME amputation, that's got its own code. That's 27888. And if you just do an ankle disarticulation, that's 27889. So you can't just code them all as BKA. In general, when we do surgery, there's one code per surgery, and almost all surgery codes have what we call a 90-day global. And what that means is that all preoperative care starting 24 hours before the procedure, the surgery itself, and all the follow-up for the following 90 days are included in this global payment. So anytime you hear somebody say, a surgeon say, well, they don't pay me for postoperative care, well, actually they do. They're just paying you a heck of a lot less for the surgery than you think you're getting paid. So there's also component coding, which is why I kind of got into this as vascular surgery, because you can't just do single codes. In vascular, a lot of it is what we call component, where there's multiple codes that you build together to describe what you're doing. And so for endovascular procedures, that includes the access, the catheter placement, the actual intervention. There's another code for what's called the supervision and interpretation of the diagnostic part of the intervention. So it can get quite complex. So just for an example, let's say here we've got a 68-year-old man with a 4-centimeter AAA and a 4.5-centimeter right common iliac aneurysm, along with a 3.8-centimeter left common iliac aneurysm. He's got the usual comorbidities, and we're going to fix his aneurysm. So if we do an open repair, we do a laparotomy, we put a bifurcated graft from the infrarenal aorta to the iliac bifurcation bilaterally. And when you go to CPT, that gives you one code, 35102. Okay? So let's say we decided we wanted to do it endovascularly. So we do a modular EVAR with one contralateral docking limb, followed by right external and left common iliac graft extensions. We do coil embolization of the right hypogastric and confirm that with an angiogram to make sure it's occluded. Then we do bilateral femoral artery exposure with a primary repair of the right common femoral artery and endarterectomy of the left. We do a left renal artery stent with selective catheterization and non-selective catheterization from the other side. And we finally place a left external iliac stent to basically accomplish the same thing, repair it endovascularly. Okay? Anybody want to guess how many codes that is? Well, I didn't count them, but that's how that would be coded. So it gets quite complex with component coding. Okay, so what are RVUs? So the RVS is the resource-based relative value scale. So this came about in about the time I was sitting in the med students' seats in med school. This was when the Clintons first took office. They wanted to kind of level the playing field. And so I'll confess that I don't know, I never practiced in an age before coding. So I don't know what it was like to just submit a bill to insurance or Medicare and this was your fee. So the idea of the RVS was to level the playing field where you can compare apples and oranges and make everything equal so you can compare across specialties and across procedures. So every CPT code then got assigned an RVU, or a relative value unit, which is composed of work, practice expense, and malpractice expense. So there's payment for how much work it takes you to do it. There's payment for what it costs your practice to do whatever it is you do, and payment to cover your malpractice for whatever it was you do. And it was supposed to make apples equal to oranges. But as you can see from my initial talk, or my initial slide, a carotid is only 1/14 of a spine exposure. So not all apples and oranges are equal, apparently. So once they come up with the different numbers, they're multiplied by a geographic practice index. So if you practice in Miami-Dade County, your malpractice is 2.5 times higher than it is in San Antonio, so you get a little more for that than if you're practicing here. And then they compile all these numbers, and that's the total RVU for a code. Well, the RVU gets important because as far as Medicare is concerned, there's a conversion factor, which is how many dollars they pay per RVU, which is set annually by Congress. And so how many RVUs a code has directly relates to how much you get paid for doing something. So what is the RUC? The RUC is an AMA committee that's the Relative Value Scale Update Committee. So this is an independent group of volunteer physicians, and these slides are directly from the AMA, by the way, exercising their First Amendment right to petition the federal government. It's comprised of 31 members, 28 of them voting, and 16 of the 28 members are from specialties whose Medicare allowed charges are primarily derived from the provision of E&M services. The RUC is an expert panel. It's not a representative panel, and its individuals exercise their independent judgment and are not advocates for their specialty. So the RUC got a bad rap a few years ago when it was called the quote-unquote secret society of physicians that fix prices for Medicare. It was a nice expose in the New York papers about the RUC and a couple of articles about it. But basically the RUC's job is to value new codes, and if codes are not appropriately valued, so therefore apples and oranges not equaling, a society can go to the RUC and say, hey, this code is undervalued, and we think it should be this. So each specialty that's recognized by the American Board of Medical Specialties has a permanent seat on the RUC. These are the different specialties that are currently on the RUC. And then there are 4 rotating seats, including one specifically for primary care, and then 3 others that can be open to anybody. So the cycle. Step 1, CPT. It starts at CPT with either new codes or revised codes, or CMS will identify codes that CMS thinks are misvalued. And so the list of codes to be valued goes to the RUC staff. The RUC staff then sends out memos to all the different RUC advisors and members asking if your society is interested in this code, interested in forming the recommendation. So you can either say level 1 interest of yes, that's very important to us and we want to be part of making that code. You can say you're level 2 where you're interested but not going to participate but reserve the right to comment, or level 3 is doesn't apply to us. We then generate surveys that are sent to different members of your society to try to gather information about how much time it takes to do this procedure, how much effort is involved, how much stress is involved, and ultimately how many RVUs you think it should be. The RUC advisors, which is me now for SVS, we compile all that data, we turn it into a summary of recommendation, and then we go to the RUC meetings, which meet 3 times a year, to present and defend our recommendations. So this process always kind of reminded me from when I was a kid, the Schoolhouse Rock of how a bill becomes a law. This is how a code becomes a CPT, becomes an RVU. And this is just kind of what I was saying. So if you have a procedure that there is no code for and you don't want to use the 99 code, you can you can contact your society's advisors and say, hey, we should make a CPT code for this. So CPT meets 3 times a year. If it passes there, then it goes on to RUC. It can be a Category 3 code, which is kind of an experimental code, or a Category 1 code, which is valued and billable. The ones that make it out of CPT, like I said, then go to RUC. RUC, we survey, analyze, make our recommendations, and then go to the meeting. The meeting is always kind of interesting. I'm actually leaving tomorrow for the very next meeting, and we have a very busy agenda. I already have previewed comments from the reviewers on the RUC that reviewed my tabs, and they don't like any of my recommendations, so it's going to be a busy, fun week. So you go to the table, you make your recommendations, you argue the support of it, and then it's like a psychology class. The RUC is psychotic. It acts as a body and kind of will move in waves. So if you hit it at the right time, you can get codes through. You hit it at the wrong time, nothing's going to go through. So if you're persuasive at the table and get your codes passed, you're done. If you lose the feel of the room and you lose momentum and too many people speak against your code, you get voted down. And so when your tab or your recommendations get voted down, then you're going to spend a good chunk of your night in what they call facilitation, which is a much smaller chunk of the RUC and a smaller room. And you sit in that room for an hour where nothing gets done for about 45 minutes until people realize they have dinner reservations in about 15 minutes. And then you look through the database and you try to find something similar that everybody agrees on and say, well, we'll give you this. You can crosswalk it to this code, and would you take this RVU instead of the one you want? And so there's a lot of blood, sweat, and tears, but eventually out of facilitation comes a recommendation, and then you go back to the table the next day and you listen to the facilitation committee report, and then 90% of the time, the whole committee will approve the facilitation's recommendation. If you have such a controversial code that you can't get something agreed upon in facilitation, or you come back from facilitation and the whole RUC votes it down again, then you're in trouble. And that usually means that you're going to have to start from scratch and resurvey the whole codes again. So after all this process is done and the final recommendations from the meeting are complete, the RUC creates a huge document that they forward to CMS as their recommendations for the code. CMS can follow those recommendations, or they can adjust the values as they see fit. As far as CMS is concerned, this is just our First Amendment right as physicians to have input into what CMS ultimately decides. It used to be kind of a rubber stamp that CMS approved about 90% of what the RUC sent them until the RUC started to get a bad rap. And so a couple years ago, they decided to kind of take a hard line, and they seemingly indiscriminately rejected half of the RUC's recommendations. It's gotten a little bit better than that since then, but it's still an interesting place. So if any of you ever get a RUC survey, you should fill it out. And there's several reasons to fill it out. One, the survey is kind of the core basis of the RV database system, or the RVS. They put the survey is like the Holy Grail. Nobody questions the survey data. Well, they question the data, but the data is the data. The minimum survey numbers for a code can vary, so the more utilized the code is, the more surveys are needed. The statistical analysis of those surveys is what really makes the RVU. And your recommendations, so when we present them, they want to see the whole spread of the data. So they get the minimum, so the very minimum value somebody recommended, the 25th percentile, the median, the 75th, and the maximum value. When I first started doing the RUC, the median must be correct. Somewhere about 8 years ago, that downshifted to the 25th percentile. We've all gotten too good at filling out the surveys, and we're inflating the data. So the 25th percentile is assumed to be correct, even though there's no statistical legitimacy to that. That's what it is. Pre-service, intra-service, post-service times are also collected in the survey that are very important into the database to compare across codes. And the average intra-service time from the survey really becomes the de facto time to perform the code. It's kind of if you ask me, kind of an arbitrary way to assign value. It seems like we have much better ways of collecting data of how long does it take to do a lap chole or how long does it take to do a colon. But as far as CMS and the RUC is concerned, the time is what the survey respondent said it was. Intensity is also very important. So the RVU per time is a big important part of the code and how they determine whether or not a code is valid. Okay, I got time to keep going. You want me to stop at ICD-10? Okay, everybody's heard of ICD-10, I take it, right? ICD is the International Classification of Diseases. This actually came about in the late 1800s. It was never really meant to to describe different codes. Forever, I was working with ICD-9, and we just switched to 10 in August. So if you ever read that book, it's just insane. Okay, so it reads like a bad encyclopedia. It doesn't make any clinical sense. I'm going to show my age, but a movie that was popular when I was a kid growing up was Beetlejuice, and I always think about Beetlejuice for CPT or for ICD because the two people that died in the movie, they had no idea what they were supposed to be doing, and every time they went for help, they kept saying, well, have you read your handbook for the dead? And every time they try to read it, it's like, this makes no sense. There's nothing that makes sense in it. So to me, the ICD is like the handbook for the dead. And it's probably pretty correct. There's a lot of codes in there that aren't appropriate, that aren't around anymore. There's 8 different codes for types of plague, but it's missing all kinds of things that we deal with clinically. Like for vascular, there's no code for popliteal entrapment. Okay, so ICD-9 was bad. ICD-10 is now the 10th revision that really kind of focused on etiology, chronicity, laterality, and what the level of encounter was. If ICD-9 was bad, ICD-10 is worse. It's crazy. ICD-9 had about 17,000 codes. That has now exploded to over 155,000 codes in ICD-10. Okay, here's some of the highlights or lowlights that coders like to send around as slides. There is a code for burned due to water skis on fire. Okay, these are real codes. All right. I like this one that somebody sent out as Dos Equis. I don't always walk into a lamppost twice, but when I do, I use ICD-10 code W22.02XD. Real code. Pecked by a chicken. I don't know why that's a needed code out there, more so than popliteal entrapment, but apparently it is, as is struck by a turtle. Okay, so maybe there's a lot of trauma in the third world with chickens and turtles and reptiles, but there's whole sections of the ICD-10 for this, and yet still missing some other things we need. So a little humor for there. Okay, in just a few minutes, I just want to touch on MACRA because MACRA is going to be very important for everybody in the room going forward. Just a little background on payment history. Social Security Act of '65 is what began Medicare. I think a nice little point on all that is when LBJ signed the Medicare law into existence, that kicked in when you turned 65. The average life expectancy of a U.S. citizen at that time was 64. So they enacted a law that they knew most people weren't going to live long enough to use. Problem is now, as we've gotten older and better at medicine, our average life expectancy is 78 now. Medicare has 4 parts. These weren't all there originally in '65. Part A covers hospital reimbursement. Part B covers physician and outpatient services. Part C came around much later, but these are the Medicare Advantage plans. Okay, so these are private insurances managing Medicare patients, and I could talk forever on that as well. And then Part D was from George W. That's the prescription drug benefit. Fast forward from '65 to '89, we had the OBRA Act. This was trying to control expenditures. This is when they started realizing that healthcare was growing exponentially and starting to consume a large part of the gross domestic product. OBRA was implemented in '92. They started setting spending and performance into certain parameters in the first part of the '90s. And when that started to not control things, along came the dreaded SGR in '97. So the SGR was the sustainable growth rate, which was this formula that tried to account for changes in volume and intensity of services, the number of Medicare patients, the growth in real gross domestic product per patient, and changes in new laws and regulations to control the rate of growth of healthcare. The problem with SGR was it was a flawed formula, and it started pushing down Medicare reimbursements. Now, back to our parts, A, B, C, and D, okay? D was brand new. They weren't going to cut that. A was to the hospitals, and the hospitals have a strong lobby, so every year the hospitals get a little bit of an increase. Anytime they threaten to cut payments to C, the private insurer said, well, you know, if you're going to cut what you pay us, we're going to drop all these patients. And so they were afraid to do that. So basically SGR, which was supposed to control the overall growth of healthcare, wound up putting all that burden onto the physicians. And so for about 10 years, we had either stability or cuts the conversion factor. So this is what I was saying before. So back in 92, the inflation-adjusted conversion factor was right around $30. And so through the early 90s, it was okay. And then right around here, 97 is when the SGR kicked in. And this is what the conversion factor should have done. This is what it actually did. And this was because of annual one-year fixes and delays to prevent the SGR from cutting physician reimbursement. If we had not gotten those delays, the SGR would have pushed the reimbursement per RVU down to about $20 an RVU from 30 by 2011. So MACRA was passed this past April. So after about 12 years of annual problems with reimbursement and SGR, we finally got the SGR repealed. Hooray, right? The MACRA stands for Medicare Access and Chip Reauthorization Act. SGR is finally abolished. Okay, but sometimes it's be careful what you wish for. So what do we have now? So with MACRA, we have an annual positive update or flat fees for 10 years. So we're not going to have any cuts. It's fixed at a 0.5% increase per year. Now, if you consider inflation relatively stable at 3%, that's actually a 2.5% cut per year, right? Because we're not going to keep up with inflation. MACRA also established the merit-based incentive payment system that consolidates some of Medicare's existing fee-for-service incentive programs. This is known as MIPS, and it also establishes pathways for physicians to participate in alternative payment models, including the patient care-centered medical home. This is APMs. So MIPS and APMs you're going to hear a lot about in the future, okay? MIPS basically combines PQRS, so physician quality reporting, value-based modifier, and EHR use, or meaningful use, into one single incentive program. So it's going to be based on your quality, so they're going to scale your quality versus your peers. How much resources you utilize, so the more resources you utilize, the bigger penalty you're going to get. Are you doing clinical practice improvement, and are you meeting meaningful use of your EHR? So based on these modifiers, you're going to have potential for an increased payment of first year is going to be 4% or a penalty of -4% on your reimbursements. And those penalties and bonuses are going to rapidly escalate where they can be as high as 9% or more before you know it. APMs is the other alternative, or the other pathway. So this is the alternative payment models. This can include accountable care organizations, patient-centered medical homes, or what they're really probably driving to is bundled payment. So if you go back to that 90-day global that we were talking about for surgery codes and people saying, well, they just don't pay me for post-operative care. Well, get ready, because the next iteration that you're going to see of that is going to be hyper bundled payments. And so for us in vascular, it's going to be dialysis access. Okay, so I don't get paid for 90 days for doing the surgery and care afterwards. I'm going to get paid one lump sum from when I first see a patient who needs dialysis access until they have a functional access. Okay, and there's going to be similar patterns for colon surgery, gallbladders, appendectomy, trauma. So get ready for large hyper bundles. Basically, MIPS and APMs, it's kind of a two-highway system for reimbursement in the future, and everybody's going to have to really kind of fall into one or the other. You're going to have to decide if you're going to do MIPS and take your risk with the escalating penalties, or if you're going to get into APMs. Okay, APMs are a little more friendly for payment, but the problem with APMs is the bar is going to jump pretty high pretty quick. So for the first year, you have to have 25% of your Medicare charges in an APM to qualify for that type of payment. The year after that, it's going to be 50, and then the year after that, 75% of your payments are going to have to be in some of these alternative payment models for you to qualify for that pathway. For people who are going to kind of ignore both and say, well, I'm just going to stick with fee-for-service, there's likely going to be significantly escalating penalties for people who stay on the fee-for-service model. They may or may not have some exclusions for people in rural areas who can't participate in alternative payment models, but their goal is to really do away with fee-for-service and drive people into MIPS or APMs in the next 5 years. All right, so in conclusion, can't believe I got through all these slides. Why should you care? All right, so you want to correctly code for the work that you do, okay? If you correctly code, then you're going to get paid appropriately for work you're already doing. You want to optimize your practice and your dictation habits to maximize your coding, okay? So, you know, if you're writing review systems negative or review systems as per HPI, you're probably reviewing a couple. It just takes a little bit of habit changing to think about, okay, well, I reviewed this and I can put this down there. Or come up with your own little quick review systems or your own habits to make sure that you're doing a complete history. And that will really make a big difference for you. It also helps you avoid audits, okay? If you're coding things wrong and you continue to code things wrong and somebody finds out about that, they can come audit you and they can make you pay back money that you've been paid for incorrect coding plus a penalty for each occurrence. I got a very panicked phone call from a surgeon in Kentucky on Friday when I was driving home that they realized that they had been miscoding fibrin sheath treatment of dialysis catheters. And they wanted to know what was the right way to code and what did they need to do with these 194 miscoded claims over the last 5 years. And I said, let me get back to you on that. I know this is more the business of medicine than the art of medicine. This is not why I went into medicine, but the reality is that this is just part of it. You can't practice medicine in a vacuum without the business aspects and the coding aspects. So, on that, I'm impressed I made it through, and I'll take any questions.
So the cynic would be that this is just an evil plan by CMS to decrease reimbursements to us. And it's driven up the cost of medicine. I mean, we have to pay coders $45,000 or $60,000 going up to go ahead and do this. I know a lot of our graduates have wives who are nurses, and then they were the business managers of their practice. I doubt whether they can do this anymore.
Yeah, I don't think it's cynical. I think it's an actual goal. I think, or maybe I'm just as cynical as you are, but I'm convinced that Accountable Care Act, MACRA, all these laws, their goal is to drive physicians into being employed. They don't like the private practicing doctor. They don't like the self-employed person because you're not controllable, okay? They want all of us to work for a hospital or work for a big organization that they can pile on rules and regulations and bureaucracy to control behavior, okay?
And that's exactly what's happening. They're driving a lot of private practitioners to work for hospitals because they don't want to do that anymore. Dr. Dent, you have the button down.
Yeah, Matthew, great talk. Yeah. I just want to kind of pile on for the residents and the young folks and pretty much everybody in the room and point out that I have seen examples over the years of people who look at how to send the maximum bill and then direct their care to send a maximum bill. And I would like to discourage that. I think what you should do is give great care and then bill to document everything you did to give the great care. But the great care comes first, the billing comes second. But what people do a lot is they underestimate things. And so if you're looking a patient over as part of their physical exam and you examine their legs and you just say, you know, no bony deformities and they're not edematous, well, that's a two-part physical exam of the extremities, like Dr. Sideman mentioned. You got your two parts there.
Right.
And it's stuff that we rarely mention. You take it for granted. There are no bony deformities, they're not edematous, but if you just noted that while you're working up somebody for, you know, the trauma or whatever, that type of stuff. It's simple things that you can do to just reflect what you actually did, to document, I should say, what you actually did. And don't underestimate the complexity of what we do. We kind of take it for granted, okay? We do it day in and day out and we take it for granted. But for example, the patient who comes in with appendicitis, who's been puking a little bit, who's tachycardic, you put in a Foley catheter and a couple IVs and resuscitate them for 35 minutes before you take them to the operating room. That's critical care. They're not intubated, they're not on pressors, they don't have a PA catheter, maybe you don't even put in an art line, okay? But I promise you that is easily billable, easily defensible critical care time, and critical care time pays very well. So if all you gotta do is document the tachycardia, okay, or any other sign of hypovolemia, and now they're in shock and it's critical care. So it's not hard to do, and the people that are doing the coding, you don't have to sell them on it. You just got to write it, and that's the whole key. You just write it. It's easy to do. And on some level, if you write anything and then bill for what you wrote, it's not fraud. Although I'd argue that seeing a shooter's abscess who's otherwise healthy except for their drug abuse problem and sending them a level 5 bill when all you did was walk down and spend 3 minutes with them and drain the abscess, it should be called fraud. But if actually you did all the physical exam and then you document that, it's not fraudulent, but I think it's marginally ethical at best.
True.
Again, I think that was fantastic talk and something obviously most of us, myself included, probably didn't get nearly enough exposure to during training. My question on the transition to ICD-10, and I sort of laughed a little bit. I don't know if there's a separate code for rooster and chicken, but a few weeks ago I could have used that code that a guy got from all
Cockfight.
Probably actually a unique code. But from a practical standpoint, obviously most of us aren't going to learn those 70,000 new ICD-10 codes. From a practical day-to-day standpoint, writing our notes, documenting the chart, what are the sort of important things that we should be doing or different, or what's different under ICD-10?
So there's a lot different between the two, and like I said, a lot of it focuses on laterality, chronicity, etiology, and so I think with the ICD-10, it's similar to CPT. Know the things that you use commonly. Okay, so you know with trauma, you need to know the penetrating ones. You need to know the non-penetrating ones. I guess you should throw a rooster in there every now and then if you're in an area where they have cockfighting. I don't know where they do turtle fighting. But know the ones that you use frequently and know the things around that. So, you know, when we all have our spare time, you know, sit down with the book or sit down with it on the computer and say, okay, well, this is the code I use, but what's right before it and what's right after it, okay? Because things that are similar are going to be in kind of the same area. And so you can learn a lot by looking into those segments. You don't obviously need to know the entire book, but you should be familiar with the ones that you need to use.
Dr. Sestero?
Great talk. I learned a few things there. I have a couple of questions for you. One is related to RUC and the method of determining new CPT codes and the value associated with them. Now, I was surprised to hear it's based off of surveys, which is one of the least scientific methods out there to make any kind of decision. Oh, it's so biased that I was a little surprised. I was wondering where data, if any data, actually makes in that decision. And along those lines, where does trauma get represented? You know, I'm a little biased towards trauma. Sure. But how does it get represented in general surgery, one of the 4 options, et cetera? The other question I have is, so with these changes that are coming along, how do we, as in our own specialty, how do we support changes that basically not favor, but to defend what we do? Is it with political action committee donations? Is it joint committees in the hospital or higher levels? What are your comments on this?
Well, so let me take your go back to the first part of the question. As far as the surveys, I was always kind of blown away that they put such value in survey data. Okay, so like for when we did carotid endarterectomy, I think I had 32 surveys for a procedure that's performed 40,000 times a year. And so based on these 33 people who actually filled out the survey, who totally off the record, half of them were on my committee, right? Because most of the time you send these emails out, these blast emails out to everybody in society, and people just throw them in the trash, right? And very few people will actually take the time to respond to them. But so based on this small number of surveys, that becomes the de facto time. And once you get the RVU passed, that becomes the value. There's much, in 1992, when this whole system started, in fact, when the whole RBS started, they had no idea where to start. And so there was a physician at Harvard named Shao, and basically Shao surveyed all of his other, he polled the audience, right? He talked to all the other people at Harvard and say, hey, how much do you think this should be worth? And so they came up with the basic skeleton from Harvard, and that's how they set everything up from the start. And there's actually still codes in the database 25 years later that are Harvard valued, right? That they haven't been touched or looked at since 1992. And some people got a good shake from Shao, and vascular surgery got a bad shake. So we started off low, and have been working for a long time to try to improve that. As far as there's lots of other better data out there, and anytime we've tried to bring better data, it's been shot down. So like NISQIP, that's got great real-world data, okay? 10 years ago when they tried to use NISQIP data for times for bypasses, the CMS representative kept calling it BISQIP at the table and said, well, this is not real-world data, this is teaching hospitals, this is VAs and teaching hospitals, these times are unrealistic, and that got shot down and gone. But there are real data sources out there, and I would like to see the surveys kind of replaced with actual real-world data. As far as making a difference individually, I think it's like everything, you do it locally and you do it globally. So you get involved in your local area, whether that be in hospital committees or in your own departments to make sure some of this stuff is done correct, and then you get involved in your own society. And so as much as I dislike politics, political action committees are important. Political action committees were key in getting the SGR repealed. And so I hate going to Washington, but I do it about once a year or so. I probably go to CMS more than I go to Washington, and that's a little more face-to-face arguing. But actually going onto the Hill and meeting with congressmen, you got to do it. I don't like it, but you got to do it. And in fact, actually, you get more mileage if you meet with their legislative director. Okay, their LD for healthcare. You talk to the congressman, and they're just a charismatic, makeup, smiley face, tell you everything you want to hear, shake your hand, vote for me in the next election kind of thing. And they have probably just a minuscule amount of knowledge about everything. But on their teams, they have a legislative director who oversees all their efforts legislatively, and then they have legislative administrators that are for healthcare focus in different areas. And if anybody's interested, Scott Kirchville, I don't think he went back out into private, but he did this for a year. He was an LA for Cornyn, and really knows a lot about the inside workings of healthcare. And the one time I went up there and met with Scott, it was the most productive meeting. I mean, we cut right through the red tape bullshit, and he's like, okay, this isn't going to happen this year because of this, and this, and what else do you want to talk about? I was like, wow, that's great. Most of the time you get all this red tape and propaganda and oh, you need to help reelect the senator. It's like, we just want the SGR gone. So.
The American College of Surgeons has actually been very active.
Yep.
Primarily, I think they were the driving force for the recall.
Yeah.
True. With that being said, you look at a lot of professional organizations like the trial lawyers and folks like that. Some of them have upwards of 80 and 90% of their members contributing to their political action committee. The American College of Surgeons has 3.8% contribution to the political action committee.
Out of about 60,000.
Out of over 60,000 members. And so it's like the lowest representation of any professional organization out there. And so they do what they can with what resources they have, but we could do a whole lot better.
I have a comment and then a question. First thing you said about the hospitals and healthcare networks wanting all of the physicians to be employees. The people coming up and graduating are also wanting that in a lot of situations too. So I've gone and talked to some folks about jobs, and in my hometown, North Texas, there's, I think, maybe 10 or 15 years ago, there were no employees of the hospital. And now, as people are coming up, there are some people transitioning over that have been in practice for a while that are becoming employees, but a lot of the new, across different specialties, including surgeons, want, I think, not to deal with this stuff, and they want just, give me a check, I'll go bill, and they don't mind. I mean, we've been employees for a while, and so, I think